Hello, classmates. My name is Alicia Washington, and I would like to welcome you to my presentation entitled Second Responders Measures Up to Improve Community Health. So the program that I'm going to be discussing today is the Second Responders Program. This is actually a program within the nonprofit organization Southern Nevada CHIPS. Nevada CHIPS is a 501c3 nonprofit offering case management, research, referrals, and navigation assistance. So through a diverse group of programs, they actually help to navigate people through oversaturated access points. So be it hospital and healthcare systems, insurance systems, social service programs. They help to provide case management service and actually handhold people, make phone calls on their behalf and things of that nature to help them get through and access the care and the assistance that they need in the community. Southern Nevada CHIPS was actually founded in 2003 by Las Vegas Fire and Rescue Assistant Fire Chief Sarah McCray. Sarah was tasked back in 2012-2013 with trying to help out with compassion fatigue among first responders because they kept going to the call. They kept going out to the calls and determining that it wasn't actual emergencies. It was more social determinants to health. And so they were getting frustrated, and she came up with this bright idea where if we brought in social work and nursing, we can create this program to actually assist and aid first responders on the back end of those calls. And that is our staple and first program. We have since grown into other programs, including our crisis response team, which responds to individuals experiencing mental health crisis. But again, for the sake of this project today, I am going to be discussing the Second Responders Program. Just so you know, I will be using language such as ours and we and things of that nature because I am currently the Assistant Director of Operations for Southern Nevada CHIPS. So, have you ever wondered what happens after a 911 call? Ever thought about what happens to those people? How do the first responders feel after the call? What kind of takes place when people are released from the emergency room? What if they don't even go to the emergency room? What kind of occurs after all the lights and all the sirens are gone? What happens to those individuals? Many of the calls that we receive with second responders are regarding medically fragile individuals. I would say about 60% of our clientele with the second responders program are those that are elderly, so 55 plus, which is not a small population of individuals in Las Vegas. This is a retirement community, so a lot of folks within that age group where family is in New York and LA and all these other places, and they don't have a lot of support. So we get a lot of calls regarding elderly individuals with slips and falls and things of that nature. And so those actually are a large group of the type of calls that I'm referring to when I'm going to be discussing this today. So when a lot of first responders that I've spoken to, we are inside of all of the fire stations, and we have a lot of contact with the first responders, and a lot of them going into this, we're thinking, I'm going to put this gear on, I'm going to be, fighting fires and cutting people out of cars and all these things of that nature. And this is true. They do a lot of that. They do beautiful and great work. And we need them in the community. But what they found was that they were going into situations where they were tasked with handling things that weren't necessarily medical emergencies or life-threatening emergencies. So some of the things that first responders are up against in the field include dealing with the medically and mentally fragile individuals who shouldn't live alone. So we have a lot of elderly people who want to maintain their independence, but unfortunately, they need a lot of supports that aren't in place. So they may be able to live alone, but they also may need a home health aide or a nursing assistant or something like that to come and visit them on a regular basis to ensure that they're taking their medicine and things of that nature. That's not something that can be addressed or remedied with a 911 call. There's also patients who have family caregivers where the family member fell ill and all of a sudden I'm responsible for this person with diabetes and I don't know anything about giving insulin or correct nutrition and things of that nature. So we have family members and caregivers who don't know how to properly care for people. Again, something that cannot be mitigated with the 911 call. We have people, unfortunately, living in uninhabitable conditions. So we have people who are living in situations where there's extreme hoarding, there's feces and urine all over the place from pets, there's just no path or no fire exit, and people get stuck in these situations. And also, they can cause different health issues. So while that may be a medical emergency for the moment, you can't return that person to that environment, or what happens? They get sick again. You also have people who have issues that require financial assistance. So someone may have had a heat stroke, but when first responders go into their residence, they learn that the air conditioner is not working because this person doesn't have enough income or enough money to pay for their electric bill. Then there's situations of suspicious of abuse or neglect, where individuals may be receiving. There may be, a case where individuals suspect that an individual receiving some sort of fixed income is having that income stolen from them. Their medication is not being paid for, their bills and their rent aren't being paid for, and they end up in difficult situations. Also, they receive a lot of calls that should be non-emergency calls for issues that should be mitigated with community resources. So we've received phone calls from individuals whose teen wouldn't clean the house or do their chores, and they were just tired of it. There's people who call and say their air conditioner broke. There's individuals who call and said that, just a host of different issues that maybe they need some therapy, maybe they need someone else to talk to, maybe there's a community resource that can help them cover a financial obligation, but it's not necessarily the job of our brave first responders to go into these homes and deal with these issues. So that's some of what first responders are up against, and kind of how we came to be and how our program came to be. So, what can second responders do to help? In these situations, our program can actually do a variety of things to help individuals who aren't really in that non-emergency situation, or first responders have identified that even if this person is in a medical emergency, something needs to happen in this situation to prevent it from happening again in the future. So that's when we come into play. So things that we can help with the second responders program, we provide in-home nursing and case management visits. So we actually are partnered with the UNLV School of Medicine and Nursing, and we can have nursing students and nursing professionals go into the home, assess the environment, assess the medication, make sure that it's livable and it's breathable and inhabitable for individuals, so we can get any of that corrected. That's including, like, if it was a hoarding issue, we actually have connections within the community where we can have a person's home kind of cleaned up and things of that nature. So with those in-home nursing and case management visits, that can be extremely helpful. We also offer navigation through oversaturated medical and social service access points. Again, we do the environmental assessments. We assist with transitional and supportive services for caregivers. So super important. My wife just got sick. She has diabetes. She used to care for me. Now I have to care for her type of situations. We're able to take that spouse, educate him on diabetes, educate him on how and when to give the medication, educate him on how to change the diet and address the needs of the individual with diabetes. So we do a lot to make sure that the caregivers have the support, including connecting them with respite care. Because say my wife is sick and I'm sick too, and I can't leave her alone, but I have to go to the doctor. So who helps with that? So we help them navigate those utilizing the existing resources. So whatever their existing income and existing insurances are. And insurance is another thing. So insurance is difficult. A lot of people don't know about like medical transportation and all these different features that are available to them through their insurance. So we help them navigate through things like that. So establishing primary and specialty medical care physicians, and just essentially increasing the quality of life within their home. So what does all this mean? If you have an individual who's calling 911 5, 10, we've even seen 20 times per month, and it's not an actual life-threatening emergency, it's something that can be addressed and mitigated through other channels, our community is losing and wasting money, and our first responders are just frustrated. every time the truck rolls. So every time Las Vegas Fire and Rescue, Henderson Fire Department, North Las Vegas, every time they have to show up to someone's home, it costs at least $1,000 to get all of the gear ready, get all the guys on the truck, get all the things, all the sirens blaring and rush to that individual's home. It costs $1,000 or more per call. So if we can stop and we can provide an intervention to get folks to stop calling 911, we can save this community tons of money. And it's been shown and proven through our interventions that we've been able to do that. We've gotten people who are calling 911 10 times a month down to not calling them at all, because we've been able to holistically address all of their needs and get them connected to the resources that they need. So to talk a little bit about systems and data collection. So what happens first is we get the information from the local fire departments. They use a system called Image Trends to collect and store all of their 911 data. We have limited access to that as well, but that is where all of the 911 data is stored. So on every address, every call, every individual, what the call type was, if it was chest pains, if it was a slip and fall injury, all of that information is collected within Image Trends. Once we identify an individual as a high utilizer, we actually put them into a system called CMIS, or Client Management Information System. And in this system, we actually get consent to enroll them into our program. And once they're enrolled into our program and assigned to one of our case managers, we actually add them into our internal case management system, which is FamCare. And just to give you an idea of the systems and what the kind of differences are, because all of them have very unique features, very unique purposes. And so I just wanted to talk a little bit about the differences between the systems. So Image Trends is owned and operated by the local city and fire departments. They actually all just got on one accord to be using the same system in the different jurisdictions, because before it was 3 different systems and it was a little difficult for us because we work for all of them. So now that they're all using Image Trend, it works and it helps out greatly. We do have limited access, as we should, to Image Trends, so we can see things regarding the referrals that we receive and individuals that have been identified and triggered in the system as high utilizers. But all the rest of that jazz is up to the fire departments and the city entities to kind of navigate. Image Trends does store all 911 data. And it is HIPAA compliant. So again, it stores all of their data and it's HIPAA compliant. The CMIS system, or a Client Management Information System, is actually a community-wide and is operated by the COC, or the Continuum of Care Board. Is actually created so all of us within the community, all the service providers, can be connected. We can see what programs our clients are enrolled in. It does have a different profile and database for each organization, so you can keep those things separate. So we do have our own platform, but it is a way to know if your folks are going to the food pantry or accessing other benefits, because you kind of know what they do know and what they don't know. And when you input them in there, if they're already there, it's already attached to their client profile, which gives them a unique mark or a unique identifier. So it's a really cool way to protect clients, to protect their confidentiality, but also to know what other services they're navigating in the system. And lastly, there is FamCare, which is our internal case management system that only we have access to. It was pretty cool. We're actually still building it out and adding the things that we need, but we were able to kind of tailor make this to the needs of our agency, seeing as though it's pretty unique with all of the varying programs that we have. But this system, again, we only have access to, it stores detailed qualitative client information. So more of the quantitative is in the Image Trends and the CMIS, but in ours is where we put all of our case notes, our detailed case notes, what's going on with the clients, and all of that type of information. And once again, it is also HIPAA compliant to make sure that we are protecting our clients' information. Moving on to measurements. So historically, what has been reported out to funders, community partners, really people who are stakeholders and are interested in what we do, has been the reduction of utilization, right? If we have people that are calling 911 10 or 20 times a month, we want to show and prove that our intervention actually prevents that. So in a lot of the reporting that we do, it's just simply referenced as calls and the overall estimate. I did go ahead and create just a simple equation that shows kind of how we figure that out. So what we do is we look at prior 90 days before our intervention, and then 90 days after our intervention, and then try and determine what type of impact we had. So if we have an individual within the past 90 days who's called 911 20 times, we times that by $1,000, because again, that's the average or the base of what it costs to roll that truck. And then we subtract that from the number of calls that they've had after the intervention. And that kind of shows the reduction in calls based on individuals as well as program wide. And it also gives an estimate of the cost savings to the community. So the bottom line, of course, is cost savings. That's what politicians want to hear. That's what our funders want to hear. That's what the fire departments want to hear. We're saving money. We're reducing those costs. That's what matters most. And so those are the numbers that we highlight. But I personally believe, which we're leaning towards and heading in this direction, and evaluating information that is more valuable and more meaningful in understanding how our system works. So our program is definitely special and unique in what we do. And the program is at a significant advantage serving solely as a case management and referral navigation agency. We do not offer any other direct services. So this allows us to work with and connect with hundreds of medical and social service programs throughout the Valley. So we essentially have a bird's eye view of how Southern Nevada systems of integrated care work. So we know how medical and transportation and social services and all these things, even religious services and providers and things of that nature. We know how all of this works and how all of it could probably work a little bit better to improve the needs of our community. So what I have recommended, I do have my 3 recommendations of things that we should just pay a little bit closer attention to and better evaluate. So my first recommendation is to have a third party come in and evaluate the qualitative data and community partners. So we do a lot of case noting. We do a lot of, individualized case plans that is specific to the individuals and their holistic needs. And so a lot of that can't be captured quantitatively, and it can't be captured in essence of a certain program or certain language. And so I would say that we need a third party firm to come in, sift through our case management notes and our case management systems and evaluate the types of programs and services that we're offering our clients and what they're actually utilizing. And this would be helpful because it could provide insightful information on how our community system of integrated care works and how we can all work together to improve upon that. And it can also serve on a small scale as a gaps analysis in regard to needs and things like that in the community. The second recommendation that I have would be intentional and aggressive client and staff survey. Right now, I'm gonna be honest, our survey system is fairly weak. We actually just mail out, once we close a case, we mail out a survey to individuals and we hope, wish, and pray that they return it. And that's not always the case. So our response rate for our surveys is extremely low. So I would suggest require developing a new survey model with a unique delivery technique. So whether that's phone calls, whether we do a final home visit before we actually close the case out and conduct the survey then, or however we decide to do it, I would say that we go another route and do it more intentionally and aggressively so we can have a better understanding of the feedback that our clients are giving us. And also that would be beneficial for program consistency and then possibly duplicating this throughout Nevada or in other states, hopefully. The last recommendation that I have is actually to establish an advisory committee. We currently do not have one for this program. I'm personally working on developing one. I think advisory committees, especially to the type of work that we do, are very important because getting that insider insight from different perspectives is unmatched by anything anybody else can bring to the table, any other understanding. So that will require building a diverse committee of clients, first responders, and community partners. It could be very insightful information from varying perspectives. They can kind of work together to help build and change and better the program. And it would provide significant guidance to the program and improving the model again so we can duplicate it and keep it going strong. So with that, those are my 3 recommendations. I do want to give a special shout out and a special thanks to all the women and men in uniform who serve our communities every day. They never know what's on the other end of those doors when they go a knocking and blowing it down, or what emergency they're coming in contact with, and they do that bravely. So we appreciate them, and we enjoy and we appreciate being able to be in all of their administration buildings, working beside them and working to improve the health and happiness of our community. So with that, bye.